Hi, I'm Dr. Mary Chryssikos with the Emory University Department of Pediatrics. Today we're going to be talking about acute otitis media. Have you heard this sound? This is the sound of a baby screaming in pain. You aren't sure why yet, but as he clutches his ears, you have a hunch that he may have an ear infection. The goals of this learning module are to promote accurate diagnosis and treatment of acute otitis media. This learning module is geared towards interns and medical students beginning their emergency medicine, primary care, and urgent care rotations. Acute otitis media is defined as an infection that involves the middle ear. There is typically an antecedent event, such as an upper respiratory infection. This results in inflammation of the respiratory mucosa lining the nasal passages, nasopharynx, and eustachian tubes. This causes obstruction of the narrowest part of the eustachian tubes, the isthmus, causing secretions to build up in the middle ear space. Microbial growth can result in separation and clinical signs of acute otitis media. The ear has an external, middle, and inner portion. The outer ear is called the pinna and is made of ridged cartilage covered by skin. Sound funnels through the pinna into the external auditory canal, which ends at the tympanic membrane. Sound causes the tympanic membrane and its tiny attached bones in the middle portion of the ear to vibrate, and the vibrations are conducted to the nearby cochlea. The spiral-shaped cochlea is part of the inner ear. It transforms sound into nerve impulses that travel to the brain. The fluid-filled semicircular canals, or labyrinth, attach to the cochlea and the nerves of the inner ear. They send information on balance and head position to the brain. The eustachian tube drains fluid from the middle ear into the pharynx behind the nose. Now let's move on to a little pretest. Question 1. What percentage of children will have an acute otitis media by ages 2 to 3? If you picked 80 to 90%, you were correct. Congratulations. Question 2. What are the most common pathogens that cause acute otitis media? Staph aureus bacillus and moraxella, strep pneumo haemophilus and moraxella, strep viridans, group A strep and bacillus, viruses, H. flu type B, and E. coli? If you said strep pneumo, haemophilus, and moraxella, you were correct. Congratulations. Pediatricians care about these pathogens in order to provide appropriate treatment for acute otitis media. Question 3. What are the most common presenting symptoms of acute otitis media? Is it fever and ear pain, vomiting and poor feeding, diarrhea and fever, or stiff neck and high fever? If you said fever and ear pain, you're correct. So why do pediatricians care so much about acute otitis media? Well, because 80 to 90% of children will have an episode of acute otitis media by age 2 to 3. Acute otitis media accounts for numerous office and ED visits per year in the pediatric population, and at this time it's largely overdiagnosed, which can cause antibiotic resistance. Let's go ahead and talk about some of the risk factors for acute otitis media. In terms of age, the peak is between 6 and 18 months. Attending daycare is also a risk factor. Breastfeeding is found to be a protective measure against otitis media. Tobacco and air pollution exposure, as well as pacifier use, limited access to care, and the fall and winter seasons are additional risk factors to ask about when examining a patient for acute otitis media. The most common pathogens that cause acute otitis media are viruses and bacteria. By far the most common bacteria are strep pneumo, untypable H. flu, and Moraxella catarrhalis. Other viral causes of acute otitis media include RSV, rhinovirus, enterovirus, coronavirus, influenza, adenovirus, and human metapneumovirus. When caring for a sick child in either the emergency department or urgent care setting, your exam and history should be very focused and concise. A focused history for acute otitis media includes asking about symptoms such as fever, earache, irritability, feeding, and sleeping. This chart demonstrates that there can be a grading system for these 5 symptoms, with yellow and red being more indicative of an ear infection. Other questions that you may want to ask are, was the child breastfed? Does the child attend daycare? Is the child exposed to tobacco? Have they had ear infections in the past? Have they ever had ear tubes or surgeries on the ears? Has there been recent antibiotic use or any allergies to antibiotics? And is the child generally healthy, or are there any underlying medical conditions? In order to get a good look at the middle ear and tympanic membrane, the child should be examined in a position of comfort, such as the parent's lap. Hold your patient's head still with your opposite hand. View the tympanic membrane as much as possible as you insert the otoscope. If wax is present, do not further insert the otoscope, as this may push the wax deeper. In order to clean the ear, first visualize where the wax is located, then pull up and out on the pinna and insert your curette with only gentle pressure applied to remove wax and avoid hitting the tympanic membrane, which may cause trauma or bleeding. Now let's take a look at some examples of tympanic membranes. In the top left corner is not acute otitis media. This is a normal appearance or effusion without any erythema. In the top right is what is known as a grade 1 tympanic membrane. This is also not classified as an acute otitis media. There is some erythema present, but no effusion. Grade 2 in the bottom left is also not considered otitis media. While there is some erythema and an air fluid level, the fluid is clear without opacification. Grade 3 in the bottom right is also not considered acute otitis media. There is an erythema, an effusion, but no opacification of the tympanic membrane. Here in the top left, we see our first example of an acute otitis media. The tympanic membrane is erythematous, opacified, and there's an air fluid level or perhaps some air bubbles and some minor bulging. Grade 5 in the top right corner is also an acute otitis media. There's erythema, complete effusion, opacification, and bulging. Grade 6 in the bottom left, another example of acute otitis media with erythema, bulging, a rounded donut appearance of the tympanic membrane. Grade 7 is not only an acute otitis media, but it technically is considered bullous laryngitis. Although otitis media is a very common pathology seen in the pediatric population, it does have serious complications if untreated. Some of the complications include tympanic membrane perforation, hearing loss, balance and motor problems, middle ear atelectasis, ossicular fixation, and the most serious being extension to supporting structures such as mastoiditis or intracranial complications. The current standard of care for treating acute otitis media is either watchful waiting or antibiotic treatment. For children older than 2 years who are normal hosts, have unilateral acute otitis media with only mild symptoms, watchful waiting is appropriate. Antibiotic treatment is recommended for children with acute otitis media who are less than 6 months old. It is suggested for kids who are 6 months to 2 years and have additional risk factors such as recurrence, daycare, delinquent vaccinations, or persistent otalgia for 48 hours, temperature over 39 degrees Celsius, bilateral otitis media, otorrhea, and uncertain follow-up. The antibiotic treatment of choice is typically amoxicillin at high doses, which is 80 to 90 milligrams per kilogram per day, divided BID. If this doesn't work, you can progress to Augmentin, and then following that would be a third-generation cephalosporin such as Omnicef. Penicillin allergic patients can use cephalosporin if they don't have a penicillin anaphylactic reaction. We are almost done. Now it's time for a quick post-test. Which of these pictures of tympanic membranes would you definitely treat for an acute otitis media? If you thought this one, you were correct. Question 2. What % of children by ages 2 to 3 will have an episode of acute otitis media? This one you should definitely know by now, and if you picked 80 to 90%, you were correct. Question 3. What is the appropriate treatment for a 2-year-old who has failed watchful waiting and is allergic to penicillin? Just a rash, no anaphylaxis. If you picked a 3rd-generation cephalosporin for 10 days, you were correct. Congratulations, you're on your way towards becoming a pro at appropriate diagnosis and management of otitis media. Keep looking at everybody's ears.